How to treat and cure hemangioma. An infantile hemangioma is one of the most common benign tumors of infancy and occurs in approximately 5% to 10% of infants. Infantile hemangiomas are benign vascular tumors composed of an increased number of unique endothelial cells that line blood vessels. They occur more frequently in female, premature and low birth weight infants. Infantile hemangiomas usually appear within the first weeks of life and grow most rapidly during the first 3 to 6 months of life. For most hemangiomas, 80% of infantile hemangioma size is generally reached by 3 months of age. Usually, growth and proliferation is complete and involution commences by 12 months of age. However, involution occurs slowly over many years, with a majority of infantile hemangioma regression occurring by 5 years of age. Although infantile hemangiomas spontaneously regress over time, some may leave residual redundant fibrofatty tissue, scar, residual telangiectasia, or pigmentary changes. Hemangiomas are non-cancerous growths that form due to an abnormal collection of blood vessels. They are often found on the skin or internal organs, particularly the liver. They are usually congenital, which means that most people develop them before birth, while they're still in the womb. Hemangiomas on the liver rarely cause symptoms. Usually, they're not discovered until you are tested for an unrelated condition. This is called an incidental finding. Skin hemangiomas appear as small scratches on babies and grow larger as the child ages. However, most hemangiomas of the skin disappear by the age of 10. The majority of hemangiomas never need any form of treatment. Some parents feel that hemangioma treatment is necessary because the marks can be disfiguring and may cause social or psychological problems. Doctors may be hesitant to treat a hemangioma that isn't causing physical problems because hemangiomas usually fade gradually without treatment and because treatments have potential side effects. Hemangiomas of the skin develop when blood vessels group together into a single lump. Experts aren't sure why blood vessels group together like this, but they suspect that it's caused by certain proteins that are produced in the placenta during gestation, the time when you are in the womb. Hemangiomas of the skin can form on the top layer of skin or on the fatty layer underneath, called the subcutaneous layer. In the beginning, it may appear to be a red birthmark on the skin. Slowly, it will start to protrude upward from the skin. On the liver. Hemangiomas of the liver form in and on the liver's surface. These hemangiomas are thought to be sensitive to estrogen. During menopause, many women are prescribed replacement estrogen to minimize the symptoms caused by the decline of their natural estrogen levels. This excess estrogen can spur the growth of liver hemangiomas. Hemangiomas can grow on other areas within the body, such as the kidneys, lungs, colon, brain. Hemangiomas that grow in the brain cavities or other cavities within the body are called cavernous hemangiomas. Hemangiomas don't normally cause symptoms during or after their formation. However, they may cause some symptoms if they grow large, if there are multiple hemangiomas, or if they grow in a sensitive area. Hemangiomas of the skin usually appear to be small red scratches or bumps. As they grow, their appearance is similar to a burgundy-colored birthmark. Skin hemangiomas are sometimes called strawberry hemangiomas, because of their deep red appearance. This type is mostly found on the neck or the face. Symptoms of hemangiomas of the internal organs. Hemangiomas inside the body usually go unnoticed until they grow large, or multiple hemangiomas form. Some symptoms that you might have include nausea, vomiting, abdominal discomfort, loss of appetite, unexplained weight loss, a feeling of fullness in the abdomen. The terminology used to define, describe and categorize vascular tumors and malformations has changed over time. The term hemangioma was originally used to describe any vascular tumor-like structure, whether it was present at or around birth or appeared later in life. The classification of vascular anomalies is now based upon cellular features, natural history, and clinical behavior of the lesion. Vascular anomalies are divided into vascular tumors, neoplasms which include infantile hemangiomas, and vascular malformations which include entities with enlarged or abnormal vessels such as capillary malformations, port wine stains, venous malformations, and lymphatic malformations. This marker has revolutionized the ability to distinguish between infantile hemangioma and other vascular anomalies. Infantile hemangiomas typically develop in the first few weeks or months of life. They are more common in Caucasians, in premature children whose birth weight is less than 3 pounds, in females and in twin births. Early lesions may resemble a red scratch or patch, a white patch, or a bruise. The majority of hemangiomas occur on the head and neck, but they can occur almost anywhere. The appearance and color of the hemangioma depends on its location and depth within a level of the skin. Superficial hemangiomas are situated higher in the skin and have a bright red, erythematous to reddish-purple appearance. Superficial lesions can be flat and telangiectatic, composed of a macule or patch of small, varied branching capillary blood vessels. They can also be raised and elevated from the skin, forming papules and confluent bright red plaques like raised islands. Infantile hemangiomas have historically been referred to strawberry hemangiomas in the past, as raised superficial hemangiomas can look like the side of a strawberry without seeds. Superficial hemangiomas in certain locations, such as the posterior scalp, neck folds and groin, perianal areas are at potential risk of ulceration. Ulcerated hemangiomas can present as black-crusted papules or plaques, or painful erosions or ulcers. Ulcerations are prone to secondary bacterial infections which can present with yellow crusting, drainage, pain or odor. Ulcerations are also at risk for bleeding, particularly deep lesions or in areas of friction. Multiple superficial hemangiomas, more than 5 can be associated with extracutaneous hemangiomas, the most common being a liver, hepatic, hemangioma, and these infants warrant ultrasound examination. Deep hemangiomas present as poorly defined, bluish macules that can proliferate into papules, nodules or larger tumors. Proliferating lesions are often compressible, but fairly firm. Many deep hemangiomas may have a few superficial capillaries visible evident over the primary deep component or surrounding venous prominence. Deep hemangiomas have a tendency to develop a little later than superficial hemangiomas and may have longer and later proliferative phases as well. Deep hemangiomas rarely ulcerate, but can cause issues depending on their location, size and growth. Deep hemangiomas near sensitive structures can cause compression of softer surrounding structures during the proliferative phase, such as the external ear canal and the eyelid. Mixed hemangiomas are simply a combination of superficial and deep hemangiomas, and may not be evident for several months. Patients may have any combination of superficial, deep or mixed infantile hemangiomas. Infantile hemangiomas are often classified as focal, localized, segmental or indeterminate. Focal infantile hemangiomas appear localized to a specific location and appear to arise from a solitary spot. Segmental hemangiomas are larger, appear to encompass a region of the body. Larger or segmental hemangiomas that span over a large area can sometimes have underlying anomalies that may require investigation, especially when located on the face, sacrum or pelvis. Unless there is ulceration, hemangiomas do not tend to bleed and are not painful. Discomfort may arise if the hemangioma is bulky and blocks a vital orifice. The cause of hemangioma is currently unknown, however. Several studies have suggested the importance of estrogen signaling in hemangioma proliferation. There is also a hypothesis presented by researchers that maternal placenta embolizes to the fetal dermis during gestation, resulting in hemangiomagenesis. However, another group of researchers conducted genetic analyses of single nucleotide polymorphism in hemangioma tissue compared to the mother's DNA that contradicted this hypothesis. Other studies have revealed the role of increased angiogenesis and vasculogenesis in the etiology of hemangiomas. More research is required in order to fully understand the disproportionate nature of hemangioma growth, which will hopefully yield targeted therapeutics to treat its most complicated presentations. The majority of infantile hemangiomas can be diagnosed by history and physical exam. In rare cases, imaging, ultrasound, US, with Doppler, magnetic resonance imaging, MRI, and/or cytology or histopathology are needed to confirm the diagnosis. IH are usually absent at birth, or there may be a small area of pallor, telangiectasias, or duskiness. A fully formed mass at birth usually indicates a diagnosis other than IH. Superficial hemangiomas in the upper dermis have a bright red strawberry color, whereas those in the deep dermis and subcutis, deep hemangiomas, may appear blue and be firm or rubbery on palpation. Mixed hemangiomas can have both features. A minimally proliferative IH is an uncommon type of IH that presents with fine macular telangiectasias with an occasional bright red, papular, proliferative component. Minimally proliferative IH are more common in the lower body. A precise history of the growth characteristics of the IH can be very helpful in making the diagnosis. In the first 4 to 8 weeks of life, IH grow rapidly with primarily volumetric rather than radial growth. This is usually followed by a period of slower growth that can last up to 6 to 9 months, with 80% of the growth completed by 3 months. Finally, IH involute over a period of years. There are exceptions to these growth characteristics. Minimally proliferative IH which do not substantially proliferate, and large deep IH in which noticeable growth starts later and lasts longer. If the diagnosis is not clear based on physical exam and growth history, most often in deep hemangiomas with little cutaneous involvement, then either imaging or histopathology can help confirm the diagnosis. On Doppler ultrasound, an IH in the proliferative phase appears as a high-flow soft tissue mass, usually without direct arteriovenous shunting. On MRI, they show a well-circumscribed lesion with intermediate and increased signal intensity on T1 and T2 weighted sequences, respectively, and strong enhancement after gadolinium injections. There are fast-flow vessels. Tissue for diagnosis can be obtained via fine needle aspiration, skin biopsy, or excisional biopsy. Under the microscope, hemangiomas are unencapsulated aggregates of closely packed, thin-walled capillaries, usually with endothelial lining. Blood-filled vessels are separated by scant connective tissue. Their lumens may be thrombosed and organized. Hemosiderin pigment deposition due to vessel rupture may be observed. The GLUT1 histochemical marker can be helpful in distinguishing IH from other items on the differential diagnosis, such as vascular malformations. The vast majority of hemangiomas are not associated with complications. Hemangiomas may break down on the surface, called ulceration. Ulceration can be painful and problematic. If the ulceration is deep, significant bleeding and infection may occur in rare occasions. If a hemangioma develops in the larynx, breathing can be compromised. If located near the eye, a growing hemangioma may cause an occlusion or deviation of the eye that can lead to amblyopia. Very rarely, extremely large hemangiomas can cause high-output heart failure due to the amount of blood that must be pumped to excess blood vessels. Lesions adjacent to bone may cause erosion of the bone. The most frequent complaints about hemangiomas stem from psychosocial complications. The condition can affect a person's appearance and provoke attention and malicious reactions from others. Particular problems occur if the lip or nose is involved, as distortions can be difficult to treat surgically. The potential for psychological injury develops from school age onward. It is therefore important to consider treatment before school begins if adequate spontaneous improvement has not occurred. Large hemangiomas can leave visible skin changes secondary to severe stretching that results in altered surface texture. Large segmental hemangiomas of the head and neck can be associated with a disorder called Faces syndrome. Large segmental hemangiomas over the lumbar spine can be associated with dysraphism, renal, and urogenital problems in association with a disorder called lumbar syndrome. Multiple cutaneous hemangiomas in infants may be an indicator for liver hemangiomas. Screening for liver involvement is often recommended in infants with 5 or more skin hemangiomas.